Good evening and good afternoon to some of us. To all of us, good evening and it's good afternoon for some of us. Welcome to this webinar titled Nurses Integrating Optimal Survivorship Care is Everyone's Business. I'd like to take this opportunity to acknowledge the Victorian Government for funding this webinar, developed in collaboration with the Australian Cancer Survivorship Centre, Cancer Council Victoria, Cancer Nurses Society of Australia, and Clinical Oncology Society of Australia. My name is Ray Chan. I'm a professor of cancer nursing, a past president of the CNSA, and the incoming chair for the COSA Cancer Survivorship Group. Tonight's webinar's focus is not only just my favorite topic, but also a topic that I've dedicated the last decade of my research on and more decades to come. I'd like to begin by acknowledging the traditional owners of the land on which we gather. In particular for me, is the lands of the Kaurna people, and I would like to pay respect to their elders and families. This webinar recognises expert skills nurses bring and a critical role they play in the management of cancer survivors. Within this webinar, our expert panel hope to address how integrating optimal survivorship care is everyone's business, and in particular how it aligns with different nursing roles. We'll discuss the importance of nurses initiating survivorship conversation, both in the acute and community setting, and to identify unmet needs and customize survivorship care using appropriate tools and support. The panelists would also explore optimal survivorship care under different models of care and discuss their lived experiences. As an introduction, I would like to share with you some of the work that we've been doing over the past few years in exploring the barriers we actually heard from nurses on the ground who are delivering clinical care for our patients. And some of these studies, what we really learned from nurses are that these barriers are very complex. Sometimes they are related to the culture in which they work, and oftentimes there's a huge focus on activities around treatment. The health system or the system that we're in a lot of the time focus on single transactions rather than the whole journey of the patients. At times, some nurses also tell us that they feel perhaps survivorship care belongs to the remit of care coordinators or specialists, allied health professionals. In particular settings, some nurses also told us that the team don't necessarily share very clear communications around the goals of care, which also makes survivorship care difficult and challenging. Regardless of what the challenges are, tonight we have an opportunity to learn from some of the most amazing nurses and nurse leaders, as well as cancer survivors here with us tonight. And to start off tonight, there will be 3 presentations. And following that, we will have some time for us to ask questions. Like any other webinar, we actually would love to encourage you to ask questions using the Q&A function. And I ask that you type them away during the presentation and across the 3 presentations, and not necessarily wait for the end. That would help us prioritize some of the questions for our presenters. To actually begin to address. First of all, I would like to introduce Cyril Dixon, our first presenter, who is the Director of Operations Support Services at Ovarian Cancer Australia. Cyril has 20 years of nursing experience across a range of organisations, including Movember Foundation, the Royal Children's Hospital, and the Austin Health. And over the past 10 years, he's been responsible for delivering national telehealth survivorship care models for prostate cancer and ovarian. Please join me to welcome Cyril.
Thanks, Ray, for that introduction, and also thanks to CNSA for the opportunity to talk, Cancer Victoria, COSA, and the Victorian Government for making this happen tonight. So always great to have some discussion on survivorship and how we can do it better for often a missed part of the care. So lots of research that's been done.
So we might still get you to swap the display on the left top corner.
Yep.
The swap display button on the left top corner. Yep.
How's
Thank
that?
you. Thank you.
Thanks, Ray. Thought I had it sorted and got it mucked up. There we go. Well done. So some of your good work, Ray, and other people in the research that we know there's a number of key top unmet needs that survivors in particular have problems with. The financial, finding their way through the health system, the unmet needs piece, having a single point of contact, lots of the psychological components around death, anxiety, fear of recurrence, worried for others that are close to you. The one that we do a little bit better at, which is the physical daily living bit. So the symptom management part's pretty good. A couple of the ones that, specific for the field that I've been exposed to around ovarian cancer and then prostate cancer as well. So they're the things that we're trying to really focus in on. The key piece that we want to do is try and make sure we focus on the problems, don't get caught up in the solutions, so that we can pivot and be agile in the things that we're doing when new opportunities come along, that we can take them on and try and come at things in a different way. So certainly the things that we're trying to work on and make a difference on are really around the unmet needs of people with cancer in survivorship, the psychological, emotional distress components, finance symptom management that we saw on the previous slide, the gaps in the healthcare system. So in particular, the focus on diagnosis and treatment, palliative care. So really trying to shift the model from being a reactive opt-in model to the proactive type model. Most of the follow-up models that we see in medicine and healthcare are usually have a focus on just investigation results, imaging, pathology, if there's any signs of recurrence, a little bit of symptom management, but usually not a lot of other time to explore issues that patients might have as they come through. In some settings, we have lots of patients who are discharged and lost from those who have done the initial treatment, and often no one really knows what's happened to them down the track. So certainly things like our registries we see with the prostate cancer and a few others at the moment starting to make a big difference in that space. Rare and complex cancers, of course, have their own challenges, particularly those that have got advanced disease and short 5-year survival rates. So they bring a whole lot of psychological support that's needed and often goes unmet for those that have that poor disease outcome. So our prom work that we've done with people with ovarian cancer, we see at the moment from the 380 women we've supporting directly, about more than 30% of those have issues with sexuality, body image, relationship, more than 30% have issues with anxiety, depression, a large number with fear of recurrence. We've got a number of people now that we've got some services around social work, etc., and our counselling for our psychosocial part, picking up at-risk people. So we've had about 5 to 6 people this year being referred to 1800 Respect with domestic violence, sexual abuse, other things, which was quite a surprise that we hadn't really been seeing before, which was pretty interesting in that space. And then a whole lot of others who are getting support around financial abuse, complexity of multiple disease, mental health, and a whole lot of that component, which is things that weren't really being picked up with just the nursing component of our care models. And 40% of the disease that we're seeing here is we're supporting of those people with ovarian cancer is 40%. The model that we in survivorship everyone's pretty familiar with is the optimal care pathway, through the middle with prevention, diagnosis, treatment, the follow-up piece, managing metastatic disease and end of life. So on this slide, we've just matched some of the key needs unmet needs that we see with ovarian cancer, and then some of the services that OCA offer, and then the rest of the services that are commonly used, just where they're doing most of their primary work. So this model that we're running, we term to be a national telehealth follow-up outreach service. community-based and delivered by NGO, not-for-profit, enables us to work across the public-private space, not be drawn into the direct hospital care, and we try and develop relationships with all the local clinicians and the primary care team. And our goal is to try and be an extension of that local care team. And in particular, we see that people, once they've finished their initial treatment or they're in remission with no signs of disease, that lots of the issues they have is they have lots of contact with everyone while they're having treatment, and then it goes completely silent when they come out the other side. So we're trying to fill that void and that gap to pick up their ongoing unmet needs. We try and be proactive in reaching into when we know they're going to have problems. When we're doing that, we're using a PROM to make sure that we're eliciting the issues that we know they're most likely to have, and have got a way to track and measure that over time in particular. When to introduce it, normally we find that certainly the survivorship follow-up program is best introduced just as people are coming out of their initial treatment and to start their recovery phase. Most services, particularly if you go into a centre of excellence where you've got tertiary MDT, a gynae nurse and other resources there, will have really good support through that diagnosis initial treatment phase. So certainly we try not to get in the way there with having too confusing or too many people. Certainly they're saying, who are you? And there's a lot of distraction with them just trying to focus on dealing with the fact they've been diagnosed with cancer and that they might die from it, and trying to shift them through that space. So we're then to support the team and maintain that contact as they come out the other side through the initial treatment piece. What we want to try and do is try and develop those niche expert services or linkages where we can, and we identify people with issues. We try and link them back into their other treating services locally where that exists. So connect in for psychological, sexual medicine type services. Usually they're difficult to access unless you've got access to a cancer centre, and even then there can be a wait for psycho-oncology support. So we offer those things remotely, which work really well. Means we can give access to the things that are high demand and often left out. Using the PROM allows us to make sure we're picking up the sexuality, body image, relationship type questions, drawing out on the financial parts. So the one thing this service can't do is do the touch and feel component. We're pretty reliant on local service to do that, but we know that most of the time it's really about having experienced clinicians who know the story and know how to elicit the right information anyway. And when they're identifying that there's at-risk concerns, being able to connect back into the treating team or the GP, depending on what those things might be. The next bit, hopefully most survivorship people are familiar with the care triangle or this component of it from NHS and Macmillan, which has been around for quite a while, and one that I certainly like to be able to talk to in the care that and models that we're delivering. So we have, as people have more needs and stratification, high number of interventions, they get a lot of acute care, complex case management, usually done through hospital care. So all the acute treating teams, specialist nurses service, psychosocial, other supporting services. Then got a range of community care pieces, and we find that as people have their treatment, they'll jump in and out and be supported through these different services. So the services we're trying to deliver are here in this space. They're trying to support that transition from acute care into community care, try and keep them in that space as much as they can. And then where we can, try and shift people into the self-managed care space. Certainly with ovarian cancer, that's a pretty difficult thing to do. With poor prognosis, there tends to be a lot of fear of death, recurrence, anxiety that means that people need a fair bit of hand-holding support to work through their disease while they have continual retesting and then deal with their recurrences as they occur. One of the things we see that we then try and support for those who have longer or chronic diseases without that is making sure we've got good information for them, online interventions, helpline support services, and mechanisms to connect them back easily through the different services as that might become apparent in that way. The biggest things that work well from the NGO being able to do this, other than just working across the services, is also being able to deliver these things across state boundaries. We initially did this with prostate cancer for a while across the country, and focused at those who were essentially well with low needs, and we quickly identified that it actually worked really well with that 25% who were likely to decease from the disease and had advanced disease just because of their higher, more frequent contact needs, and then being able to work out when they need to be back in the clinic and not, so you can develop that relationship with the local nursing teams and clinicians, oncologists as that might be, to do that. One of the difficult things we see, and Olivia Wong at Peter Mac, one of the psychiatrists there, was really instrumental in helping shape this type of work, was the use of opt-out language for referrals. So one of the things we know is it's really difficult to get people to take up referrals. Quite frequently, people use the language of, hi here, Ray, we know you're having a bit of problems, we know, with your relationship or whatever. What I want you to do is, here's a number to call Penny. She's really good as a psychosexual counsellor. So if you give her a call, and she'll be able to help you out. Most often people don't take up that opportunity because it's left with them. So one of the things we try and do is change that dynamic a little bit, and would use the example of, hi Ray. One of the things that we would want to be able to do is start to know that lots of people at this point in their disease have lots of problems with this. We've got Penny who's really good at talking around these things. What I'm going to organise is for her to give you a call and then have a chat to her and see how you go with that. If that works for you, then it's good and keep going. And if not, then we can see what else we can come up with. The barriers that we find really is a lot of clinicians have to work through the trust and ownership. They want to own their patients, believe they're doing everything that they need for them. There's a lot of fear of losing patients, and that's pretty strong amongst most services. Once we develop the relationships, all our nurses are 5-year plus experience with gynae nurses in the prostate cancer. When we were doing that, we had the same effect, so that both people with the disease and then also the clinicians can work quickly with them once they realise that they're able to operate in that way. Communication takes a while, often one way. So certainly we're often just communicating back with letter, email, etc., to clinicians to help them shift through that space. With what we've been seeing and doing, and usually with phone calls for anything urgent in that way. One of the things that works well is where we're being able to CC into GP letters, other referral letters, so we can just be across. And so once we establish those relationships with local care teams, that's something that works quite well. The current program we've got, it's got 350 people across Australia. That was of August, and the unknown 18 are the ones who are just newly referred, who we haven't got going yet in that way. There's 6 EFT of nurse, so 9 nurses in total working part-time across 3 states. People just see, our nurses just see people from wherever, so it's not a state-based service. So we try and allows us with a better way to have cover. We use Salesforce internally to be able to track our tasks, so that when people have leave or need to pick things up, that's easy for us to do as a team in that way. One of the things we see is lots of great feedback. People love the services we have, and once they start using it, they're pretty keen to be able to keep referring us as people to support, and want to offer more. One of the things we've had is, this service is so good, can I send all my gynae patients to you? We've got Deb and all some 2 key clinicians who really refer us a lot of women and are pretty supportive of the program. Our people who with ovarian cancer, they really appreciate the work that the nurses do, and are pretty frequent in the awesome feedback they give to the work that we do in the service. So thanks, Ray, and everyone. That's
Thank you, Cyril, for the presentation. And I think what you've really run us through tonight is a great telehealth sort of model that you've been working on through OCA, which is amazing. We started receiving some questions, and I would encourage people to continue on to send us questions via the Q&A function. The only reason that we ask you to do that is just so that we don't miss important questions coming forward. Now, after Cyril's presentation, we actually have a poll that we would just sort of like to hear from the participants. So if we could please bring that up, great. How often do nurses practice reactionary opt-in? Call me if you have any issues. We're interested in your thoughts, and we'll give people around 10 seconds or so. When we have enough responses, we'll share with you the results. And Sarah, I'm gonna get you to, we actually do have a little bit of time. I'm gonna actually get you to stay online and actually get your thoughts about what the results might be.
Yeah, absolutely. So I think that just to answer Kim's question around the PROM, the one we're using at the moment for ovarian cancer is the most, and that works well. We use that as a clinical tool, share it back with clinicians where we can. And we've just got a series of a couple of extra added ones we add on. We do GHQ because we find the most isn't sensitive enough for anxiety, depression. The one experience we've had over a long time is we just find that the distress thermometer is not sensitive enough for all the specific pieces. They just don't get called out when people complete them. So we think a specific PROM works much better. And we were using the EPIC 26 with prostate cancer.
Well, interesting. How often do nurses practice reactionary opt-in? Call me if you have any issues. And of course, many of us do think that it is frequently very interesting result. Well, please join me to thank Cyril. We will move on to the next presentation, and once again, we will have a Q&A session after the 3 presentations. Next, we would like to welcome up our second presenter, Josh Hart, a nurse unit manager at Peter MacCallum Cancer Centre's Parkville Radiotherapy Unit. Josh has got over 12 years of experience as a cancer nurse, and also his postgraduate qualifications in cancer and palliative care. Josh is also a clinical lead at Peter Mac for strengthening hospitals' responses to family violence, delirium, and behaviours of concern. Josh is passionate about staff and patient wellbeing, and I'm sure that will be shown through his presentation. Thank you, Josh.
Thank you very much for the introduction, Ray. It's very kind of you, and thank you very much, Cyril. That was amazingly interesting. I'll just continue to share my screen. Does everyone see that okay?
Yes.
Okay, so thanks, Ray. So shifting the focus from illness to wellness and starting the conversation. I don't need any more introduction than that one, so we'll just move straight on. So learning objectives for me today are how does survivorship fit into an acute oncology setting and our survivorship process, engagement of staff, how to start the conversation and provide information while patients are still going through acute toxicity, and the importance of experience and knowledge when delivering survivorship support. So just to give you an overview of where I'm from and why this has worked and why the challenges have existed that we've gone through. RT Nursing at Parkville is a very busy unit. I've got 2 workflows here, trolley bay and nurse-led clinics, but the overview is we see through our actual department about 150 to 180 patients a day, and we see between 40 and 80 of those patients. In our nurse-led clinics, we do a lot of education, comprehensive assessment, wound care, routine review, psychosocial support, education around toxicities, coping strategies, and referrals. And that's not, that's some of the work we do, but it's not the only work we do. And in trolley bay, we do invasive and complex procedures, unplanned unwells, including sepsis and hypothermia, which are 2 major workloads when it comes to unplanned unwells, and escalating pathways from clinics, pediatric inpatient care, adult inpatients and delivery and preparation for CT contrast. We also do quite a lot of cardiac monitoring for patients who have indwelling devices that are receiving external beam radiation. So pretty busy nursing group, only 6 to 8 nurses seeing all of those patients. And if just a few of them are unwell, we've got some pretty heavy work on our hands. So moving forward, to our process. So I'll talk through our process and how survivorship fits in with us and where we've gotten it to before I talk about how that happened and what the challenges were. So what are survivorship packs? I don't know if you can see to the right there, we've got a picture of one of our survivorship packs. These survivorship packs are delivered on the last day, and they're customizable and are delivered with education as well. So a lot of our patients are in 7 weeks of care. So 33% of our patients are head and neck patients, and they all get between 6 and 7 weeks of radiation. And this pack is actually a culmination of that 7 weeks of care in a lot of ways. So I'll talk a bit more about our process at the end of treatment in the next few slides. And the pack contains a personalised treatment summary, which involves a list of past treatments, including their chemo or surgery and their radiation, details of their treatment team, and other supportive information that we can enter manually. It also includes some information sheets, which are varied, but we've selected a relatively large handful, but we can chop and change what we put in there, including fatigue, exercise information, fear of cancer returning information, external links to support organisations, and very importantly, business card of ours, which means that they can call us anytime, and sometimes 6 months after they've seen us for their last appointment. So that's our basic process. It'll happen at the end of treatment. So we'll have a final treatment final review with our patients, and in that space, it's usually relatively administrative. So finding out whether or not they've got all the scripts they need, finding out whether or not they've got transport booked, or if they need if they've got the medications they need, or if they've got the dressings to discharge with. So outside of it feeling quite administrative, we can also give them this pack, which is sort of something that will hopefully make them feel like they're not just being abandoned after a long series of treatment. So I guess I'm not really an expert in survivorship per se. I'm a nurse unit manager, so my expertise is staff engagement, I hope, and so that's what I'm largely focused on in this context. So with the engagement of staff around this, it took a lot of time. It took actually a couple of years to really get this off the ground. I'm happy to report that we gave our 200th pack out last Friday or sometime last week, but it obviously took a lot of time to embed or start embedding a new process. So any cultural or process change, especially in nursing, medical care takes time. And that was one of our one of the most obvious things that we came up against. Assumptions about what patients wanted or needed. So assumptions from us as nurses. So there was some attitudes around about whether or not the patient had the inclination to engage with this material, especially at the end of treatment, or they just want to go home, stuff like that. Being expressed by our nurses. So, and a few other assumptions about, big packs of paper and not wanting to bother the patient with this process. So education was a big part of staff engagement as well. So staff like to be expert in information delivered generally. So it was very clear over that 2 years that without the nurses understanding, without my nurses understanding what was included in these packs and their link to what we deliver as acute clinicians, there was not going to be any engagement. So education from the survivorship team, but also re-engagement from me and other people was really important about getting nurses to engage. And linking active treatment to survivorship was absolutely key. So after treatment summaries, I've talked about already, but since the EMR was introduced in our hospital, it's become incredibly easy to push a few buttons and produce a very personalized after treatment summary, which has all of the information about that patient's treatment. So they can take it to their GP, or they can just hold it with them so they know what they've gone through, the names of their drugs that they've been taking, all of that stuff. And yeah, also other things in there that have, information about, things to ask your GP and stuff. So linking what we've been teaching them with their survivorship care. So resourcing was another thing. So I'm usually very protective of my staff when it comes to introducing new processes and things that value add to a patient's experience. But generally, it's clear that when we're trying to increase a patient's experience or plug a gap in patient safety, even it a lot of the time falls to nursing care. So it doesn't seem to be doctors that pick that up. It seems to be nurses. It doesn't seem to be allied health necessarily. It seems to be nurses. And so my attitude towards this, and that's why I've got non-engagement next, my attitude towards this at the start was, hang on a minute, we need to resource this. This is, my nurses are incredibly busy, and you can see a picture of their amazing faces there and some of them. We need to resource this. It's not entirely fair just to keep adding things onto the care we deliver. But it actually became really evident, especially after the EMR was instituted and we can have that ATS that we can personalize for the patient. It became really clear that survivorship and survivorship packs were actually resourcing us. It was a very clear continuum between the supportive care that we provide and the self-care that we teach and the education about everything from treating their pain to right amount of exercise and eating and drinking actually flows really seamlessly into survivorship care. So it was about actually connecting those two things and making sure it wasn't just an other and a pack of paper. It was actually, we've talked about this for 7 weeks. Take this with you. You're not alone. And we're not just abandoning you at the end of this treatment. And here's our business card and everything else, hopefully, that you need in here. So my engagement was essential to that, obviously. And not that I didn't engage in the start, but I really did need to fully engage. I'm the one that puts this stuff together in my department generally. So, having me engage with it and value it obviously lent itself to my staff valuing it. Well, I hope that's the way it worked anyway. So starting the conversation with patients. So education is our core business, and it starts on day 1 and continues through treatment. Survivorship fits really well in this space because surviving well through treatment and survivorship are obviously now innately linked. And our survivorship packs are end of treatment packs. We don't use the word survivorship initially because if they haven't heard it before, or it seems to be a buzzword that doesn't necessarily resonate with a lot of our patients. So end of treatment packs it is. Until we start going through it with them, obviously there's a lot of survivorship information on the top and we can explain what that is to them. And it summarizes the culmination of many weeks of supportive care and includes invaluable information about self-care and invaluable supports. These packs are tangible, so they can actually take them with them, even though they're in acute toxicity and all sorts of other things going on. They can take these away with them. They're personalized, so we actually put different information in different packs. And so we need to know what the patient's been through and what they're about to go through in order to personalize those packs to a relevant extent. So they're relevant to the patient. And this empowers the patient to move from this acute care that they've been through with us to a space where hopefully they've got the resources to self-care and also access the care ongoing that they need. The challenges that we face once again were time. So actually we are busy people and actually spending more time. It will take, sometimes 10 or 20 minutes to go through one of these packs so someone understands them. It's really interesting stuff, but it actually does take extra time. So, if we do have 60 people on our list and it's getting towards the end of the day, this does come into it. So It needs to be valuable. It needs to be part of our practice. It needs to be not just a value add, but something that we really consider to be part of our workflow. And once again, the assumptions that we made about patients just not wanting to engage with that stuff. They're in pain, they're tired, they've got reaction areas, they're not thinking about this stuff. But because we've been speaking about all of the supportive care and education throughout their treatment, it's not really about initiating a conversation whilst they're going through these acute toxicities. It's about giving them a pack that represents all of that good work we've done throughout the treatment that they've been through. Staff engaging with the value of providing survivorship packs. So really talking about, what it means. Does it value add? And actually the experience of the appreciation of the patient when they receive these packs is key to this. And so the amount being given out has been ramping up, because it actually turns out that they do want them, and the treatment summary is really important to them. But all the other stuff, like questions to ask when you come for your follow-up appointment, and how your GP can help, these are really great pieces of information that they wouldn't have engaged with necessarily otherwise. And also changes a relatively administrative review session to something that is actually very supportive and valuable. One of the things we do administratively aren't valuable, but they're obviously not very exciting. Supply of survivorship packs. So actually, having them available, having the information to putting them available, putting them together, making sure it's not just a from scratch, trying to get business cards in there, trying to get all the information. So there's a base one that's available, and other things can go in there from all sorts of sources. So they're very customizable, but the base of them is ready, and they can just be picked up by I know I'm seeing this patient for their last day of 7 weeks of treatment. I'm just going to grab one of these packs and sort it out for them quickly and print out their after treatment summary, and it's ready to go. So having the packs not put together in the first place is definitely not something that works. Staff familiarity with survivorship pack materials. Obviously, the less familiar staff are with the material, the less likely they are to deliver the material. So obviously ongoing conversations about what's in there and the importance of them is absolutely necessary in that context. Patients and family, can you get home? It's actually a reality sometimes. So delivering the packs, even if it's quickly, is important, but knowing that, knowing how to read a room and having experienced staff that know how deep a dive to take into these packs is essential. But it's still a challenge we face. And of course, the obvious toxicity, pain, fatigue, all the things that we've caused through our cancer treatment and that cancer causes. Hopefully we've stabilized their pain and we've educated them enough to make their fatigue not overwhelming. But at the same time, sometimes that's not always possible. And even if we have stabilized their pain and their fatigue, it still will be in the background, and worry will still be in the background. So obviously, engaging with this stuff needs to start early, needs to start on day one when they're feeling well, and continue throughout. So what supports the delivery of survivorship care in RT at Parkville? So we're a relatively well-resourced unit. We are very busy people, but we don't have ratios. We can spend time with patients one-on-one until we're finished with them, while still considering who else needs to be seen for the day. Got a high percentage of very experienced staff, over 50% CNS in my group, who actually are very good at reading a room and explaining survivorship care and what the patient's been through. A team that embraces innovation. So my team will embrace everything that makes sense and is a value add for a patient, which is amazing. They're an amazingly curious and dedicated group of nurses who will always embrace something that value adds, not just for them, but for the patients. And a culture of holistic care and continuation of care embedded in the culture. So when we're seeing a patient who's getting head and neck treatment and they've got a leg wound, we will treat that wound throughout that 7 weeks. We're not going to just leave it because it's not radiotherapy, and we will treat that wound after they're finished, and we will supply them with dressings weeks and months after they're done, if that's what's necessary. So that is part of our culture, and that's what's delivered by my amazing nurses. So we also deliver daily treatments. So we've got the opportunity to see patients daily. We build rapport amazingly well with these patients. And so delivering this care is right up our alley. And radiotherapy is frequently the last mode of treatment, as I've talked about before. So it's pretty hard to deliver survivorship care if they're going to go on to have more care after that. And we have the ability and the resources to provide ongoing phone support. So take-home messages from me are empowering patients to help themselves in nursing is core business for nurses, not just my nurses. And survivorship and surviving well during treatment are innately linked. Conversation about self-care and surviving well should start on day one of treatment, especially if you're the last one off the rack. Having staff that are competent and confident in having conversations and difficult conversations about self-care and survivorship, not just illness and treatment, is key. So, you know, everything from sexuality to fatigue is really important to have, and I have a great staff base that can do that. Individualized survivorship packs with ATS after treatment summaries and patient-specific brochures. So it needs to be personalized. Otherwise, it does come across sometimes as just a stack of paper. And if it hasn't been engaged with before that, then it's going to be really hard to make it seem valuable to nurses or the patients. And like any procedural or cultural change, the move to embed this new practice has taken real effort and time, and continues to require leadership. So revisiting this stuff is important. It's not going to stick around if you don't talk about it often. And our amazing survivorship team at the VCCC give us that support really amazingly well. That's it from me. Thanks, Ray.
All right, thank you, Josh. It's really, really interesting to hear from a NUM perspective, and it's very clearly showing that you're really concerned about patient well-being. So thank you for sharing that. Now we're going to run a poll just to hear from people what they think about the radiotherapy that's offered at Parkville, why they actually think they lend itself so well to provide supportive survivorship support. Let's see what the outcome is. All of the above. Well done. Thank you so much, Josh, for sharing with us your experience, especially at the radiotherapy unit. I think there is a lot of potential across a number of radiotherapy units across Australia. Thank you for your presentation. Thank you. Now we're going to introduce Bethany Crowe, who is our last presenter. Beth is a McGrath metastatic breast cancer nurse and a nurse researcher at the Princess Alexandra Hospital. She's got 30 years of nursing experience, predominantly in oncology, specializing in breast cancer care since 2004. Bethany is a member of the CNSA and the Queensland Cancer Control Safety and Quality Partnership. And she's also the nurse researcher on the Ibis breast cancer survivorship study, which I happen to lead. Please share your presentation with us, Beth.
How is that? I'm working.
Yep.
Okay. Hello, everyone, and good evening to you all. As Ray just mentioned, I work on the Ibis survivorship study with him. And the Ibis survivorship is about implementing a nurse-enabled shared care follow-up model for early breast cancer survivors. So I'm representing all of those organisations tonight. So we know that shared care models for early breast cancer follow-up incorporate a chronic disease approach. They're consistent with Cancer Australia statements, the optimal care pathway for breast cancer, and international guidelines. They've been shown to be logical, acceptable, safe, cost-efficient, and patient-centred. So it's a no-brainer, right? But maybe not. So despite the promising evidence base and the widespread endorsement, the current model of early breast cancer post-treatment follow-up care remains mainly specialist-driven and focuses on surveillance for disease recurrence rather than holistic care needs. So why isn't shared care follow-up the norm? Some of the barriers that have been identified or reasons identified are the lack of a key champion, lack of overall coordination, lack of infrastructure, lack of GP confidence in delivering the care, and lack of information for GPs about cancer and its treatment. There's also no RCT providing high-level evidence on the efficacy and implementation of the Ibis or of the survivorship shared care. So this is Ray's study. As you can see, Ray's the chief investigator, along with a lot of other prestigious names from our country. The Ibis survivorship study aims to address a lot of the barriers to shared care. It's a hybrid implementation effectiveness randomised controlled trial, and it encompasses the implementation of the Ibis survivorship nurse-enabled shared care model, an assessment of its effectiveness and cost effectiveness. Implementation of the Ibis survivorship nurse-enabled shared care model was underpinned by education of the specialist cancer nurses delivering the Ibis intervention. So the nurses are supported to complete the EverQ Cancer Survivorship course, in addition to a purpose-built online course with content provided by Professor Jane Turner and from Professor Chan that focuses on the Ibis survivorship nurse-enabled shared care model. It's a bit of a mouthful, sorry. Promoting self-management using the 5 A's self-management model, and advanced communication skills such as motivational interviewing, promoting self-efficacy, and cognitive behavioural techniques. Consolidation of the learnings from these education opportunities are also supported by regular clinical supervision for the specialist cancer nurses on the Ibis survivorship study. So clinical supervision encourages the specialist cancer nurses to reflect on their learnings and their experiences with patients to increase their awareness and ability to manage their own thoughts and feelings that arise. For example, if a workplace structure and culture focuses on the acute, or say what we call serious health problems, in which the patient is the one who initiates the clinical contact, the nurse may be purely reactive to the patient's concerns. However, upon reflection, the nurse may identify that these underlying thoughts and they may adapt their practice to start to include a more patient-focused approach, engaging in monitoring of healthcare needs or promotion of preventative measures. As part of the Ibis survivorship study, the specialist cancer nurses actively promote the nurse-enabled shared care model. They advise patients, GPs and specialists of the benefits of shared care. It's safe, comprehensive, cost-efficient and acceptable. They facilitate effective and timely care coordination and communication by acting as the conduit between the specialist cancer nurses, specialist cancer teams and the GPs. Feedback from GPs in a pilot study for Ibis highlighted the need for early engagement between the GP and patients for effective shared care to occur. And engagement between the GPs and their patient can be promoted by encouraging the patient to see their GP throughout treatment, promoting the GP's role in holistic care, and if the patient doesn't have a GP, encouraging them to identify one or even just a GP practice early in their treatment trajectory. And you can find some more information that can promote shared care on the Ibis survivorship website listed here. The Ibis survivorship nurse-enabled shared care model consists of 3 active ingredients encompassed in the development and communication of a shared care plan. So there's a standardised shared care follow-up between specialists and GPs, the specialist cancer nurse-led clinic to complete a draft of the survivorship care plan, and a GP case conference where the specialist cancer nurse discusses and finalises the survivorship care plan with the GP. The Ibis Survivorship Shared Care Plan is developed by the specialist cancer nurse in collaboration with the patient. It's designed to address unique physical, social, emotional and spiritual concerns of the individual and help them to feel confident about coping into the future. It includes the treatment summary, embraces the shared care model of follow-up and promotes self-management strategies. Completing the treatment summary and follow-up schedule can take some time, but by starting it early, for example, when the patient's treatment plan is discussed at a multidisciplinary team meeting, and liaising with the treating team to tailor the Cancer Australia follow-up guidelines to your local service, you can make this process more efficient. Reaching out and communicating an agreement with the specialists and about standardising time and frequency of follow-up can ensure that everyone's on the same page and you're not negotiating an individual follow-up plan with for each patient. The next step in is the specialist cancer nurse-led clinic. It's with the patient, and there's the survivorship care plan draft is developed, and there's the treatment summary, information links, and follow-up schedule are reviewed, and 1 to 3 self-management goals are developed. So when identifying and developing the self-management goals and strategies, research tells us that simply providing information or telling a patient what to do doesn't necessarily result in change. I don't think any of us like really just being told what to do. So rather than deciding what the patient needs and providing it, the specialist cancer nurse adopts the coaching role, so assisting, encouraging, and sometimes gently suggesting. So the specialist cancer nurse works with the patient, supporting them to reflect on their experiences and assisting them to identify their needs in order to co-develop and document the self-management goals and strategies to maintain and improve their health and well-being. This can be tough as nurses who are action-focused want to fix things, but it's important to remember change can be incremental, and sometimes it's good to plant the seed early. The specialist cancer nurses often have contact with their patients throughout treatment, and they can use these on-treatment consultations with the patient to start assessing what health-related changes are important for them. Finally, so at the GP case conference, the specialist cancer nurse collaborates with the GP in reviewing and finalising the survivorship care plan, and that might be incorporating some GP feedback. It promotes the understanding of the patient's disease, treatment, follow-up, self-management goals, provides information resources to support self-management and side effects of treatment, and importantly for GPs, it also gives them a direct contact for the specialist cancer nurse to seek advice or facilitate rapid review of the patient if needed. Just a tip, so GPs and specialist cancer nurses like us all are busy people, to streamline the GP case conference, it's great to liaise with the practice manager to book first thing in the morning or just after the GP's lunch break, and that tends to avoid delays in starting the conference. In addition, engage the practice nurse in the conference. This assists the GP to claim MBS payment and to develop and coordinate the CDM plan for ongoing care. So in summary, the Ibis Survivorship Nurse-Enabled Shared Care Model aims to address many of the barriers to shared care for early breast cancer follow-up. So it nominates the specialist cancer nurse as a key champion and coordinator, provides GPs with information about the patient's diagnosis, treatment, follow-up schedule, side effect management and self-management goals. It considers the MBS funding for GPs to support shared care follow-up, and it's developing the body of high-quality evidence of the efficacy and implementation of a nurse-enabled shared care model. Thank you. And answer your question. Thanks, Ray.
Thank you, Beth. Thank you, Beth. Really informative presentation to really give people an overview of this comprehensive nurse coordinated program. So we've got a poll here now, just to sort of help people sort of consolidate their what they have actually learned from Beth's presentation. If people can actually start picking the right answer of all these essential components of the Ibis Survivorship Care Plan. I will share the results in a minute. Yes, we 33 out of 35, so we've got 94% of the people answered this correctly. Thank you, and thank you, Beth, for the presentation. Now, if I can just invite up Josh, Beth, and Cyril to open the camera back on, so that we can actually begin to ask you to answer some questions. And we have a very limited time for questions, but I'm going to throw out a couple of questions anyway. One question that can be addressed by any one of you: why is it called survivorship? From the experience, some patients don't like the term survivorship. So who would like to address that? Maybe Beth, I'll get you to answer that one.
Well, I'm not sure why it's called survivorship, because it isn't a good fit sometimes, because often people don't like the term, and I know I've struggled with it before, holding survivorship days for patients, and we actually ended up changing it to a Cancer Warriors Day. So I probably can't answer the question why. I've racked my brains for years to think about an alternative term. It's just that it's so many journeys and journeys is another one of those words, but so many experiences for individuals that maybe trying to find one word is too difficult to describe it.
Yeah. It is good to note that NIH recently qualified the term by actually stating that survivorship is actually used to describe a population, but it's not meant to be used as a label, because some people actually do not resonate with that term. So it is important that we don't use it as a label, rather we use it as a functional term to describe a population when it comes to actually sharing of knowledge, conferences, research, etc., etc. But we should not use it as a label, because some people don't identify with that. Now, I've got another question for Josh. What do you do, Josh, with your regional and rural patients? How do you sort of link people back to the community for support? A nurse navigator, nurse coordinator, etc.
Yeah, so a large part of our business is making sure that care continues, and so part of that is referrals and making sure that people understand what we're doing. I mean, reactionary care, so the care that comes after what we've sometimes done to patients, is actually a bit unique in the way that you treat it. So it is very normal for us to write, and actually EMR's helped with this a lot as well, write a letter to describe the care that we want them to deliver. But a lot of the time we will deliver 2 to 4 weeks of dressings, which is a large thing of dressings for someone to go home regionally, because it's a very expensive kit. So yeah, we refer, absolutely. If someone's close to us, of course, they're welcome to come back to get that care. But we absolutely do a lot of written communication with regional providers. So community healthcare providers.
Thank you, Josh. Now, Cyril, a question for you. How do you involve the family in your support and education for the patients?
Yeah, good question. Thanks, Ray. Usually where we can, the nurses and or our psychosocial services connect with the partner as well, and usually either both together or fire them up. We've been running since the start of this year a male partners group, just to pick up those pieces, and then in particular where we identify these relationship issues, then we try and support him with different people caring for different people in that way, to pick up all the things around that when we're looking after any person impacted with ovarian cancer, that includes the whole family, significant others in that way. So we see that as critical in doing that, and certainly having our social worker and counsellor available now to support the services allows that to happen, because they often just get lost or left.
Great. Well, thank you, Sarah. And thank you, everyone. Thanks to all the presenters for sharing your knowledge and your experiences with us. And I'm sure that the audience really appreciate it. And there were remaining questions that we have, but unfortunately we don't have the time to cover them all. But hopefully later on at our panel discussion, we can potentially raise some of these issues as well. So thank you, Josh, Cyril, and Beth. So now it comes to the exciting time of panel discussion. Always like to have a little bit of a chat about some of the experiences that different people with different perspectives have. And tonight we're very lucky to have 3 people who are joining us. And if I can get Kim, Catherine, and Anne to turn on your camera to help us better understand how nurses can integrate optimal survivorship care, and to further highlight some of the issues. We've got these 3 expert panelists. And first of all, we have got Kim Hurley, who is a consumer representative residing in Victoria. Kim was diagnosed in November 2019 with follicular lymphoma and is currently in remission, undergoing immunotherapy. Hi, Kim. Second, we have got Catherine Lane, who is the head of Cancer Information and Support Services, Cancer Council Victoria. Many of you might have seen Catherine in multiple billboards and YouTube videos while you're waiting in between videos, so she should not be a stranger to anyone. Last but not least, we have got Anne Mellon, who is a long-term colleague, amazing clinical nurse consultant in gynecological cancer, who works in the Hunter New England Centre for Gynecological Cancer in Newcastle, New South Wales. So thank you for joining us tonight, and we're looking forward to learning from you. So first of all, I'm going to just start with you, Anne, if that's okay. How can we as nurses integrate optimal survivorship care in our usual practice? So, not out of the moon, something that we actually have a lot of special efforts that we deliver it on a particular day, but actually a usual practice. How do we do that?
I guess it's about starting those conversations, at every opportunity that we have, finding the teachable moments with our patients to talk about those survivorship issues, like making lifestyle changes that can improve, how they tolerate their treatments, as well as how they whether they have a recurrence of their cancer or not. And it's about making that usual practice in our everyday. We have lots of time as nurses that we do spend with our patients in a one-on-one situation where you can just start those conversations. And even though the patient may not be willing at that very first conversation to start opening up and having that chat with you, at least you're planting a seed. And then they can have a think about it, and then they may be in a better position at a subsequent time where you see them to be able to sort of talk more about those sorts of lifestyle and survivorship changes.
Yeah, great. So, Anne, this question is not on the list, but what is your message to the nurses who are caring for 4 to 6 patients at a time? Running around, giving blood, giving chemo, extremely busy. Some people are newly diagnosed. Some people are sort of in between treatment. Some people are probably coming in for symptom management. What is your message to them who are running a busy shift? How do they actually begin to prioritize or somehow integrate survivorship care's conversations with patients?
Yeah, I guess, and I can understand, that everybody works in very busy units, and it is hard to find that time. But it is, when you're, hanging a bag of chemotherapy, or you're doing a dressing with a patient, just starting those conversations, actually asking them, how are you going? How are you managing at home? Is there anything that you need help with? Just sort of planting those seeds and starting those little bits of conversation. And sometimes people are a little bit reticent to sort of, be asking for extra help. But even if they know that you've actually opened up that, that question to say, well, is there anything else we can do for you? Then they may become more willing and more comfortable. And it's building that rapport over time, I guess, as well. So if you are having them back for repeated treatments, whether that be radiation or chemotherapy, or seeing them on a surgical ward sort of, days after surgery, just having those repeated conversations when you see them can be really, really helpful and allow them to become more comfortable with you and actually divulge some things with you that they do need help with.
Yeah. What are some of the hints and that patients tell us that we know that they might be in a teachable moment, that they're ready to receive or that they're ready to actually discuss about things?
Yeah, I guess it is when they're starting to open up to you and revealing things that they may not have revealed to someone else before, that new knowledge, or when you sort of are talking to them about what their treatment has been like or what treatment they've had, and asking them, well, tell me what you understand. And when they're able to repeat things back to you and not fully understand what they've already been informed about, you're thinking, okay, well, maybe they didn't quite understand that. Maybe this is the moment where I can go, okay, well, do you understand that, your cancer in specific? I do a nurse-led endometrial cancer clinic for patients with low-risk endometrial cancer. A lot of those women don't understand that the endometrial cancer diagnosis can be related to your weight. Having that conversation, do you understand that your cancer diagnosis is because of your weight, and we can help you to make some lifestyle changes so that down the track you have a lower risk of your cancer coming back and that you tolerate treatment well. So having those conversations and starting that information. And it's important also, as people have already said in the presentations, about involving their family and their support people, because often you find they're the ones that are, there with them on a day-to-day basis. So having that message not only to the patient, but to the people that are caring for them and living with them is also very helpful.
And I think sometimes from talking to patients, what is also very important to note is that actually during active treatment, patients can already have longer-term survivorship concerns. And I think one of the things that we actually encounter a lot is around financial toxicity. And I remember during COVID times, how many patients actually began to tell us how lucky they felt that there were the COVID sort of payment that was actually provided to them, and begin to actually think about what are some of the longer term issues around sexuality, some of the other things that are more concerning survivorship. Are they actually relevant right now? And I think it is important that we think about what we can do actually at the moment and what might be the specific needs at a time.
Exactly right. I think we often focus on the actual treatment time, and we don't tend to think ahead as nurses about what those patients, what might happen for them down the track, and what's happening now can have an impact down the track as far as, are they able to go back to work and what that means for them and their family moving forward.
Yeah, exactly. Thank you, Anne. Very interesting. And thank you for your thoughts. And we might come back to you later on again. So, Catherine, coming from a sort of community-based services, how do we shift people's perception about the role of these organisations like Cancer Council Victoria and the services that they provide?
Oh, there's so many things we can be doing, but I think what I've been reflecting on throughout the presentations, and I think even starting with Cyril's presentation and talking about the idea of those patient-reported outcome measures, and I think everyone on the call will be familiar with the research that talks about unmet patient needs and the fact that they can change and evolve over time. And I think that's where community organisations really come into their own, because none of these amazing services or studies or support programs that we're talking about, and even 13, 11, 20 and Cancer Council services, none of us are resourced, nor are we able to be there 24/7 with patients and carers. And that's why we really need to work collaboratively, because those needs will evolve over time. Many of the patients that we're dealing with have never been through a cancer experience before. So the idea that they know where to go or will know who to contact and know what questions to ask is not something that we can assume. And that idea of assumptions was raised a couple of times. And I think it's a really important one for us as nurses and clinicians, allied health staff, to really think about, and thinking about that idea of, we often hear around the idea of, distress screening and these patient-reported outcome measures. Whether you screen or whether you don't screen, it doesn't matter, because those unmet needs are still going to be there. So it's so important to ask the question at whatever time point a person is in, take those teachable moments that Anne's just referenced, and think about, It might be that your health service doesn't have the type of resourcing that Josh has spoken about, or doesn't yet have a shared care model that Beth spoke about, or a teal support program like Cyril has. But 13, 11, 20 and Cancer Council services, they can pick up that reference point and take whatever it is that the patient is needing and look for what services are available. And I think the biggest strength of a service like Cancer Council is that we will, and it is our job to, refer to any and all services that someone needs. So it's not just about Cancer Council services, it's about any other NGOs that might be available, community-based services. Have you connected with your GP? Is your clinician aware of these questions and concerns? And really that is our whole entire job, is to link back, but really importantly, to then also connect and feed back to the treating team and health service about those referrals that are being made. So the idea that services don't exist or that resources aren't there to support a patient, for me, that is where community-based services are your lifeline. If you have no services available, if you have no resources in your health service, you don't have the FTE, refer someone to Cancer Council 13, 11, 20. And thinking about Cyril's point around that, that more opt-out approach, make it proactive. There are health professional referral forms on the Cancer Council websites where you can make a proactive referral with consent to really maximise that teachable moment and to make sure that those unmet needs are addressed.
Yeah, thank you so much, Catherine. I'm just interested in your thoughts. If I'm a nurse at the chair side or the bedside, what, as someone who is the head of support services in Cancer Council, what would be the top 2 or 3 things that you really want me to mention to my patients if I have got a single opportunity to be able to share with them about community services?
Absolutely. And I think the idea that, often we know that health services now have expected KPIs around supportive care screening or making sure that they're asking patients about their supportive care needs. But as we know, if you're not actually doing anything with that information after the screening's been complete, it doesn't do anything. Yes, you've ticked the box, but you've not actually achieved any outcomes for that person. So the biggest thing for me is, as Anne said, take whatever moment you have available when you're hanging the bag of chemo or doing their OBS. We have no problems asking people about their nausea, their bowel habits, what their weight is doing. Ask them how they're going emotionally. And that can be, it doesn't have to be in that way, but generally nurses in allied health know their patients so well. We're in oncology because we see them regularly. So you're the person that is likely to pick up when something's different. And if you can do nothing else, hi, I'm running in between chairs at the moment, but I can tell you're having a really difficult time. I don't have time to stop and have a big conversation about it. But if it's okay with you, I'm going to make a referral to Cancer Council, to the psychologist, to whoever it is, because I really feel like there's something here that you need to chat about, or you've mentioned in your screening that finances are a bit of concern at the moment. I'm going to put a referral in for you because I don't want to miss that conversation, but I just can't have it right now. There are so many different versions of that conversation that you can squeeze in, from a 30-second signpost to a much longer consultation, depending on what you've got capacity for. But you've got to take the moments when they're presented, because, as I said, those unmet needs are going to be there whether you ask about them or not. And whether it's 30 seconds or a longer consultation, it's still better than nothing.
Thank you, Catherine. I think your point about an earlier point that you made about, there's so many community-based services, and Cancer Council actually can act as that triage point and actually refer out to the other organizations, because oftentimes what we find is the patients are confused. There's so many organizations out there, and it is very clear to me that Cancer Council doesn't actually have that philosophy of actually competing, but actually complementing across the system. So thank you for bringing up that point, and it is very important. We'll come back to you in a minute as well. So very keen to come to Kim. Kim, tell us about your experience. Did you have an end of treatment consultation with your nurse or your clinicians, and were you actually referred to any community-based services?
Thanks, Ray. So after my chemotherapy, no, there was nothing. I was just sent off to radiation. So 5 weeks of radiation. I think for me, because I am being seen regularly for immunotherapy, maybe that's yet to come. However, there hasn't ever been a discussion around survivorship. And on that note, I would like to just say, for me, survivorship feels like it's a phase. It's a phase of the journey. And now I'm in that phase. I love the term living well with cancer, like something that has a really positive, optimistic, looking forward type of language around it. Yeah, so I haven't been offered survivorship specifically. The treatment packs that have been talked about sound amazing. Like, I would think that would be an incredible tool to walk out after I've done my chemo. I have something to go to my GP with, instead of just saying which I did. I showed up and said, okay, I'm here to see you. What do we do now? And he's like, I don't know. What do you need? And I'm like, I don't know, you tell me. I'm supposed to do survivorship now, but I don't know what that means. I don't know what that looks like because I'm still in active treatment. So having that treatment pack, the questions, I feel like that would really link in well. And for me personally, the nurse-led clinic consultation, when I hear that, and everything Catherine has said about linking in with the person during treatment, it's a very medically based model, and it's incredible. Like, Australia offers incredible service. We're very grateful for that. But for the psychosocial aspect, for me, that's been the biggest hurdle. It's been the biggest gap. It's been the biggest unknown. And I still don't even know what I don't know that I'm not facing or dealing with yet. So.
Yeah, that's great. Thank you, Kim. Now, Kim, having said all that, what would be the top one tip that you would want to give to the nurse clinicians who are sort of listening to this around how they can best support their patients?
Look, I feel like Catherine's covered it really well and really clear, is that if you can't have the conversation, ask them and just say, I'm going to get someone to phone you. Is that okay? I think by being proactive that way, the person, I bet you 99% of the time won't pass that up. But if you say, call me, 99% of the time, I'm not going to call you.
Yeah, unless if things go to pear-shaped again. And sometimes you don't want to wait until the time. No, that's really good. Thank you, Kim, for your feedback. Now, I'm just going to open up the conversation. There's been some questions in the chat box around COVID. Can you share with me how you have cared for people with COVID, or at least are very fearful of actually getting COVID? Some of your patients. Maybe we start off with Catherine, and then we'll go to Anne, and we get Kim to share her thoughts as well. Catherine?
Yeah, absolutely. I mean, I'm coming from Victoria, so cancer councils obviously exist in every state and territory, but I don't think anyone would be unfamiliar with the fact that Victoria has been quite hard hit probably over the longest period of time. And I think the impact of COVID, like all of us, was seen so starkly via our 13, 11, 20 service. We're about 1,000 connections up year on year still for the number of connections that we're getting. And the themes of the inquiries we've had have essentially mirrored what all of us have done in learning about COVID. In the beginning, it was about what on earth is COVID? What are the symptoms? When do I get tested? How does it impact my treatment? How do I get access to my medicines and so forth? And, you know, right the way through now, in and out of lockdowns here in Victoria, different changes to visitor restrictions at hospitals, the huge amount of supportive care screening and needs that went unmet and are even untalked about just because of the sheer restrictions on hospital care and lack of access to allied health, and a rapid transition to telehealth, which was mostly phone-based and not face-to-face, even via a screen. And now we're obviously dealing with questions around vaccines, impact to treatment, just even with the most recent announcement about a third dose for immunocompromised people and who's eligible for that. They are the questions that we are getting day in and day out. And we're lucky that, you know, we have nurses on our phone line who are oncology qualified and working across the public and private system. So they're not just working in it in a supportive care space, they're working in it in an active treatment space. So for us, from a supportive care perspective, it's been about working with other NGOs to ensure that the FAQs we've created are consistent across the sector, Cancer councils have taken a lead in that because we're not tumour specific, so we can work more broadly. Looking at our advocacy efforts and how we feed the data that comes via our 13, 11, 20 nurses up to policymakers and to task forces that are making decisions and feeding back about what the biggest challenges people are facing from a patient and carer perspective are. So as much and all as it's been a hugely challenging time, and I think we're all very ready to see the other side of COVID, whenever that might be, and we know that's some time away, we've been in a really unique position to actually put the patient voice first in all of this, and to really look at a supportive care space that was already challenged, but to look at the additional impacts that COVID's had. And yeah, it will be really interesting to see what happens over the next few months here in Victoria to open up, and we're watching very closely what's happening in New South Wales.
Yeah, so and coming from New South Wales, thank you, Catherine. Coming from New South Wales, I'm going to tweak my question a little bit. We know that COVID has an impact on screening. How does COVID and many other things, how does COVID have an impact on survivorship care from your perspective?
I guess the biggest issue that I've seen is that people are afraid to come to major centres for their follow-up care and for their, for what would be their supportive survivorship face-to-face consults with their medical team. People are worried about coming to the major centres, especially we have a large proportion of our patients who come from rural and regional areas. So for them to come to Newcastle, which hasn't had huge numbers of COVID, but they're worried about coming from an area where they've got no COVID to coming to areas that do have COVID, especially when we've had sort of some small in-hospital outbreaks, that is really concerning to them. So then they're delaying their follow-up treatment. And again, of course, that then brings the extra worry of, what if I have something go wrong and I have a concern? How do I get seen in a timely fashion when I really don't want to go to those major areas? And if I do go, can I bring someone with me? Am I allowed to have someone come to a consultation with me that I'm particularly worried about fear of recurrence or have other issues? When I have to go and do that on my own has been really, really difficult for them. I only had a conversation today again about with a patient who is still tossing up whether she should have the COVID vaccine or not, and what do I recommend, and what should she be doing, and what are wanting to know down to the what are the statistics of how people in my situation are managing after they've had the vaccine, and what if they don't, and can I get an exemption if I decide not to? It's really a lot of those worries, and providing that extra supportive care for those patients when they physically can't come to us. And we, again, like Catherine was saying, have turned a lot into telehealth, and that's a lot via telephone, and just sort of reassuring patients that if they have a concern, yes, they can come, but for those who can stay away and are managing quite well, trying to keep them away from those major centres if they can.
Yeah, thank you, Anne. And I think once again, I highlight the complexity that that survivorship care is so multidimensional. And it actually interacts with all the other parts of cancer care. And once patients don't want to come in, you sort of miss the face-to-face opportunity and how we actually navigate through that. Although telehealth has been increasingly used, we still actually see a lot of challenges. For example, physical examination and some of the more sort of sensitive discussion around advanced care planning, for example, is very, very difficult to actually be done over telehealth. So I'd just like to thank everyone, thank all the panelists for sharing your wisdom, your insights. We really, really thank you, and it's been great hearing from you tonight. So other than learning from our panelists and our presenters tonight, we also wanted to highlight that there are a lot of great resources available for health professionals and patients and their carers that they can access, and we encourage you to check out these websites, and also in particular the CNSA supportive care resources page that we put together to support people going through a journey in their survivorship. So we encourage you to do that and highlight that to your patients as well. One information source that we'll highlight also is the Cancer Australia website around vaccines and COVID, and there's pretty good information there. Now, we love polls. We'd love to hear about your thoughts. We would love to have more discussions and have way more Q&A. But at this very point, towards the end of our seminar, we would like to know your perspective about whether this seminar has increased your confidence in integrating survivorship care for patients with cancer. So if you can let us know your thoughts, that will be amazing. Drum roll. People are still putting in their responses. Do we have the outcomes? No. That's okay. Well, we'll feed that back to you later on if we can in the chat. But at this point, it's very important that we highlight to you one of the most amazing conferences across the year, which is our Cancer Survivorship Conference, the 4th Victorian Cancer Survivorship Conference. The theme is Shifting Gear, Rethinking Survivorship. It is hosted by the Australian Cancer Survivorship Centre and the VCCC Alliance, and it will be hosted next year on the 24th and the 25th of March in 2022 in Melbourne. When I saw this conference being organised, I was like, finally, we actually can dream about seeing people in real person. So we do encourage you to consider submitting an abstract. Abstract is now open until the 19th of November. And please do visit the website, www.survivorshipconference.com.au. Now, towards the end of the conference, we really would love to hear your feedback. It will just only take you 2 minutes, but as you can imagine, a lot of time when we put these sort of webinars together, it takes a lot of resources. And so we're really keen to hear your feedback, how we can improve, what are some of the sort of topics that you really want to have covered, but also for us to demonstrate back to the organisers that there is a continual need for us to put these webinars together. And so a link has been put into the chat box. We really appreciate it if you can actually spend 2 minutes to give us some feedback. And on that note, I'd just like to thank all of you for giving up your Tuesday evening to spend with us. And we know that you love survivorship, but ultimately, all of you are dedicated clinicians and nurses who actually care about the well-being of your patients. And together, we just want to thank you for your attendance. And I would like to thank the organisers as well, and all the organisations who are behind this webinar, and all the presenters and panelists. Thank you very much, and I wish you a very happy evening. Thank you.
Thanks, Ray.
Thank you, everyone.